Thank you. So indeed, I took this opportunity to talk about a huge medical challenge, which is the management of intestinal fibrosis, especially associated with Crohn's disease. So some of you may be familiar with these kinds of pictures. So this is a stenosis in a patient with Crohn's disease in terminal ileum, which obviously needs to be resected. And this region of stenosis, as seen here, is characterized by excessive deposition of extracellular matrix, and there is virtually no healthy mucosa left anymore. And this stenosis or these strictures, they can occur upon a background of still active inflammation. However, they also can occur upon a background with virtually no inflammation. So I told you that it's a common complication in patients with Crohn's disease. However, also some patients with ulcerative colitis, about 5%, suffer from excessive fibrosis in their colon. And this has some complications in terms of bowel movement, of colon shortening, for example. Treatment is non-existing in terms of drugs. However, treatment is mechanical, so resection is often necessary. Strictureplasty is often involved, so where they open up the stricture and close both ends on the opposite side so that the lumen again is opened up. And balloon dilation can also be used if it's not too severe. And over the last decades, especially with the introduction of biologicals, of anti-TNF, we have been very well able to treat inflammation in these patients. However, we now also know that the incidence, in fact, of these complications, of these strictures, have not reduced in this period of time. Fibrosis and tissue failure in general is, in fact, a huge problem. It accounts for 1/3 of deaths worldwide. And only this year, a couple of months ago, a review paper in the New England was published showing all the options that we have to treat tissue fibrosis. For example, in cardiac fibrosis, liver fibrosis, kidney fibrosis. However, they are all virtually ineffective, let's say, in the longer term. And as you can appreciate from this slide, fibrosis in IBD, intestinal fibrosis, was not even mentioned. There is, however, some preclinical evidence that we can target fibrosis using data from other pathologies. For example, there are some anti-TGF neutralizing antibodies that induce some matrix metalloproteinase production in fibroblasts, in vitro at least. Piper gamma agonists have been used, and they are able to also block the effects of TGF-beta, and they are effective in the chemically induced colitis, which was also introduced by Lou this morning. Angiotensin inhibitors and angiotensin receptor antagonists, such as captopril, losartan, they also block TMBS-induced intestinal fibrosis. Then there is silengitide, which is a beta-3 integrin inhibitor, is also effective in mouse models. And a very nice paper published mucosal immunology is the monoclonal inhibition of TL1A, which is also a risk factor for IBD, which belongs to the TNF cytokine family, is actually able to reverse even fibrosis in a DSS-induced colitis model. Now, if you look at these treatment options, we are basically blocking effects of TGF-beta because this is the pro-fibrogenic cytokine. However, I do think we need to be cautious on this, since TGF-beta signaling, especially in IBD, has anti-inflammatory properties. It blocks, for example, T-cell proliferation. So we really have to find a way to balance out the TGF-beta function if we block TGF-beta. Pharmaceutical interests for clinical trials in IBD to target fibrosis is virtually non-existing. However, some pharma have expressed their interest. Of course, this is linked with the duration of such clinical trials. It takes a number of years to develop fibrosis, so it's a very costly trial. And there is also no non-invasive way to longitudinally follow up on fibrosis. So we cannot do, for example, interim analysis. And another major issue is that not all patients develop strictures. So we need to have a tool that can identify those patients that are at risk to put in clinical trials. And therefore we need biomarkers, and there are none today. And in view of this, we also started to screen for a number of usual suspects, let's say, a number of matrix degrading enzymes in a cross-sectional study using our patients that had inflammatory disease for more than 10 years, so they will not probably develop stenosis anymore, against those that have a proven stenotic disease. And you can find some markers that are upregulated, for example, in stenotic patients, or upregulated only in those that have inflammatory disease. So at this moment, we are including our most associated markers in a larger prospective study. So hopefully within 5 to 10 years, we can show you some of these data. We often talk about the 3 phases of Crohn's disease. So most patients have this pure inflammatory disease, up to 40%. However, over time, many patients develop either fistulizing and or this fibrostenotic disease. Now, whatever triggers this progression is not known. And although we do have these huge genome scan data so far, there is only like one gene, it's a NOT2 gene, CARD15, which is repeatedly associated with complicated disease in Crohn's disease. So we still have no clue why these patients would progress. In terms of extracellular matrix contribution, so both fistulizing and fibrostenotic disease have a component that has to break down the basement membrane underlying the epithelial cell line, which is produced by innate cells that infiltrate the mucosa. In fibrostenotic disease, what we see is this completely disorganized mesh of excessive deposition of fibrils. So fibrosis, stenosis is only the one end of the one extreme end of fibrosis in IBD. But if you look at the other causes of IBD, or the other characteristics of IBD, which is increased permeability of the epithelium and elevated endothelial permeability, this also requires ECM, this extracellular matrix redistribution, and it requires remodeling enzymes. So this is a really nice picture that was published in Gut this year, using two harmonic, I can't remember the name, I never saw it before. So it's a special technique that visualizes the extracellular matrix, which is shown here in red, so collagen fibers. Here in green is just some autofluorescence. This is a healthy individual, the colon of a healthy individual, where you see this nicely organized collagen structure with the epithelial cells still intact, whereas in IBD, you see loss of collagen or deposition on some places. There is also holes within the collagen structure. And of course, epithelial cells, they are nearly vanished. We also see upregulation of a large number of enzymes. Whatever enzyme that is involved in matrix turnover is increased in this tissue. Also, for example, cytokines that are involved in fibroblast activation, such as IL-6, IL-13, TGF, are highly increased in these tissues. Now, what about inflammation and repair and fibrosis? What is the connection between them? This is a really, really intriguing question, because now we know that apparently anti-inflammatory therapy does not reduce the incidence of complications. Also, the severity of fibrosis is independent of the intensity of the acute flare-up. And probably this has to do with the 2 cytokines that are involved in IBD, which is TGF, which is, as I told you before, anti-inflammatory, however, pro-fibrotic, and TNF, which is the opposite. It's pro-inflammatory but anti-fibrotic. So this raises a number of questions, of course. It's whether if we control inflammation, maybe we are inducing fibrosis. This is a very controversial subject, and there is some evidence pointing in that direction. For example, patients that have been treated with anti-TNF do show more deposit of ECM in biopsies in a small study. Some have argued that for fibrosis, if fibrosis is suspected, that you need more early and very aggressive therapy. However, when you induce such rapid mucosal healing due to corticoids, it also induces a pro-fibrotic expression signature. So it's really complicated. Whatever inflammation is necessary for the initiation of fibrosis, but its progression is probably partly independent of inflammation. And I do believe that we need to uncouple both processes. What about the pathogenesis of fibrosis? Very general. If you have an insult to your epithelial layer, this secretes some cytokines involved in innate immune triggering, and these cells produce cytokines to effector cells of fibrogenesis, which is in IBD, in fact, is fibroblasts. They proliferate, they secrete a number of pro-fibrogenic molecules. And in normal situations, so during homeostasis, during acute inflammation, these cells, so the effector cells and fibroblasts, myofibroblasts, they need to be eliminated by either senescence, apoptosis, or autophagy. Now, what happens during long-term and during recurrent inflammation, you not only have innate responses, you also have these massive adaptive responses that further trigger effector cells of fibrosis. For some reason, the cell death of these myofibroblasts does not occur. And we also have a autocrine loop of fibroblast activation because of mechanotransduction. So integrin signaling, the stiffness of the matrix also induces proliferation of these cells. Fibroblasts during fibrosis, where do they come from? First of all, you have, of course, your endogenous fibroblasts that become activated upon secretion of innate effector cytokines. Your enteric flora also plays a big role in activation of fibroblasts. Then there is also this so-called epithelial to mesenchymal transition that plays a role in IBD. Also endothelial to mesenchymal transition. And there's also a number of circulating progenitor cells, bone marrow-derived stem cells, or so-called fibrocytes that invade the tissue whenever they are necessary. So we have been working with these fibroblasts for 2 years now, and they have some very remarkable features. For example, they are completely resistant towards TNF or fast ligand-induced apoptosis. If you culture them for even more than 72 hours and you read out caspase reactivity in various concentrations with and without the addition of TGF-beta, they survive. They're very happy. They don't suffer at all. Do they react to the TNF? Yes, they do, because if we add TGF, for example, TNF receptor is highly upregulated, and they secrete large amounts of IL-6 upon TNF stimulation, which is even further potentiated if you add TGF. So they are highly responsive to TGF, to TNF. They just don't die, which is quite remarkable. They're also highly resistant to LPS-induced cell death, only in the presence of TGF. So when they become the activated fibroblasts, they survive. So this is without TGF, so the normal fibroblast and LPS. So proliferation decreases, whereas if you add TGF, they divide happily ever after. They're also very highly resistant to hypoxia, which might not be too surprising because the gut is a very hypoxic environment. So the black bars are cells grown in hypoxia. These are skin fibroblasts as a comparison. So skin fibroblasts, they decrease in cell proliferation. And our intestinal fibroblasts, they live further and they secrete high amounts of, for example, IL-6, IL-8, whereas the skin fibroblasts, they don't secrete anything in hypoxia. So this makes it very difficult to study, of course, apoptosis in vitro, as you can imagine. So the aim of the study that I would like to present today is to use a so-called Rho kinase inhibitor in experimental models and also in fibroblast function. So we had the opportunity to work with a very small biotech company that produces these very specific Rho kinase inhibitors to test. So Rho kinase is very central to TGF-beta and integrin induced actin polymerization, for example. So globular actin is polymerized into filamentous actin. And upon release of this globular actin from its transcription factor, this transcription factor further induces genes that are involved in cytoskeletal organization. And on top of that, the Rho kinase is involved in phosphorylation of myosin light chain, which then causes contraction of your cells. The major benefit of this strategy is that we are not blocking TGF signaling, we are blocking myofibroblast transition. So this is the compound that we use. It's a small molecule. It's very potent. If you look at IC50 compared to fasudil, for example, which is a well-known Rho kinase inhibitor, it's highly potent. Also EC50 on MLC phosphorylation is much more potent. And another benefit is that they have so-called localized action in the intestine. They are degraded upon systemic exposure to the blood. This is just PK in colon tissue of mice. So it's rapidly upregulated after a couple of hours, and then it decreases, it declines. However, concentrations are still above the EC50, up to 24 hours. So what about in vitro evaluation? If we add this compound to TGF-stimulated fibroblasts, you don't see the actin polymerization, as suspected, of course. You don't see vinculin deposition anymore. And if we look at the secretion of TGF-beta, of IL-6, IL-13, and mRNA profiles as well, you can all inhibit them by adding this inhibitor. And this is also a dose-dependent inhibition. It does not, however, influence phospho-ERK induction, which is a part of TGF-beta signaling, which is a good sign, because we don't want to block TGF-beta signaling, of course. One way to try and find out what is actually happening in these cells is using ultrastructural imaging. So these are control fibroblasts. These are fibroblasts that are being cultured with TGF, so they differentiate. And you see this deposition of fibrils, very typically. If you add the Rho kinase inhibitor, you don't see these fibrils anymore. For some reason, and we still don't know why, we see this huge buildup of glycogen granules. So somehow they switch metabolism. I don't know why. If you quantify this, you see these tremendous amount of glycogen granules. Number of fibrils, they go down upon Rho kinase inhibition. And another intriguing thing that we saw is, of course, if you add TGF, you see this endoplasmic reticulum, which is highly swollen, but it might not be too surprising because they are highly secreting cells, so it's not too surprising. If you add the Rho kinase inhibitor, we still see this swollen ER, but what we also see is autophagic bodies increasing. Autophagic bodies, they are so-called recycle mechanisms within a cell that is in stress. If you quantify this again, you can see a significant upregulation by Rho kinase inhibition. Also, if we plot for P62, which is the autophagic marker, which is degraded upon autophagy, we see indeed a reduction of P62 in our treated cells. Next, of course, we wonder whether this autophagy induction does have some functional consequences. And we looked for this at IL-6 secretion. So these are control cells. These are cells stimulated with TGF, so it's upregulated. If you add our compounds, it goes back to baseline. And if you add bafilomycin, which is a blocker of autophagy, you lose this reduction potential. So it does have some primary effects, the autophagy that we see. So we are still looking into this in more detail to try and find out what is happening. Second is the in vivo evaluation. We used it in 2 models, which is the chronic DSS-induced colitis model. So we add 3 cycles of DSS to the drinking water, and then they develop this fibrosis in the colon. And also in T-cell transfer colitis, where you add CD4 positive T-cells to your mice, to your immune deficient mice, they also develop inflammation associated with fibrosis. So these are just some results. I'm not showing every detail on this intervention study. If in your normal DSS mice, your colon weight to length ratio highly decreases, which is the shortening of the bowel, the thickening, the weight of your bowel that is increasing, and this can be inhibited by adding 3 milligram per kilogram of the compound. We did a Masson-Strick Rome stain for fibrosis, which is shown here in blue. So this is a healthy mouse. This is a DSS-treated mouse. So you see this thickening of collagen, especially in the mucosis, in the muscularis mucosae. And this can be inhibited by treating these mice with a Rho kinase inhibitor. If you do some alpha SMA staining, which is a characteristic of myofibroblasts, you also see a reduction. If you look at all various cytokines that are expressed in the gut related to fibrosis, again, you see a reduction. That's, for example, collagen, matrix metalloproteinases, but also we do see some innate cytokines going down. For example, CXCL2, which is a chemokine, and TNF is also not upregulated in our treated mice. This is just another way of showing all the markers that we measured in our mice. So the green mice are those that have been treated, the red mice are those that have been placebo treated. So every dot is a mouse, and you can nicely separate them based upon expression signatures in these mice, in the colon of these mice. And if you do so-called S-plot analysis, you can try and identify those markers that are associated with your treatment. And if you look carefully, then we see mainly matrix metalloproteinase action that is differentially expressed, but not, for example, IL-17, MCP1, so the pro-inflammatory markers. They are not targeted by our treatment. Another really interesting thing that we saw, if you stain for both alpha SMA, which is a fibroblast marker, with tunnel staining, which shows apoptotic cell death, and you try to quantify the double stained cells, we indeed see that we have more tunnel positive, alpha SMA positive cells. So meaning that we might have some evidence that also our fibroblasts actually die from apoptosis in using our treatment. But as I said, we cannot confirm this in vitro, unfortunately, because we don't have a really good trigger. This is just some data on the Rho kinase inhibitor using T-cell transfer model. These are weight data, but we don't see any differences on weight loss, in fact. But we do see, again, differences on colon weight to length ratio in our double-treated mice. So this is only treated with a reference compound, and these are treated with a reference compound and our Rho kinase inhibitor. So you see reduction in colon weight to length ratio. And also on trichrome stain, they have less fibrosis as compared to our reference compound. I didn't show you all the rest of the data because we also have so many negative data, in fact. So this compound is, for example, not effective on acute inflammation. So if we use acute DSS model, TMBS model, we have no effect on disease activity, MPO analysis, histology, no effect at all. It also doesn't stop, for example, the release of IL-8 from TNF-induced epithelial cells or macrophages. In chronic inflammation, idem, so disease activity in these mice is not less. They also don't have any additional effect on barrier protection, for example. We looked at enterocyte apoptosis induced by LPS, and there is also no effect there. So just to show you that, I only show you, of course, the data that were positive on the fibrosis side. And then finally, I would like to end with some ex vivo evaluation of this compound also in ileal biopsies. So much like Lou showed this morning, we use explants, biopsies in fact, and also we isolated some fibroblasts from resection material. So here, incubated biopsies in red are biopsies taken, endoscopically taken from a patient with, at that time, stenosis. So these are the red lines. And the other ones are biopsies retrieved from a patient with active inflammation. And you can easily see that all these pro-fibrotic genes are highly upregulated in some patients, and you can ex vivo reduce the secretion of these pro-fibrogenic factors upon culturing for 24 hours. And then finally, if we isolate fibroblasts from the stenotic region, as shown here, or from the healthy mucosa from that same resection material, and compare it to healthy mucosal fibroblasts, we see that, so this is a very busy slide, but the most important thing is the black bar where we, in fact, incubate these fibroblasts with TGF. So you see an induction of IL-6 secretion in the healthy fibroblasts. But the most important thing is this one, is that those fibroblasts that were isolated from a stenotic region, they highly secrete IL-6. So they have some kind of memory of being there. And more importantly, we can block this IL-6 release if we add, together with the TGF-beta, the Rho kinase inhibitor. So that was it. So to conclude, this Rho kinase inhibition can inhibit the progression of fibrosis in 2 mouse models of fibrosis without, in fact, affecting intestinal inflammation. It interferes in myofibroblast activation and induces autophagy, and it also reduces ECM component secretion ex vivo. So what I make of this is that we probably want to have an add-on, since it does not influence inflammation. We need an add-on therapy for immunomodulating therapy in patients that are at risk for stricturing disease. So these are the people from my lab, especially my mentor, Professor Martin de Vos, I would like to thank. And in bold are the people that have actively contributed to this work. So thank you.
Thank you very much for your excellent talk. If you have some questions, please.
Thank you for this nice talk. Do you believe that we think in preventing fibrosis or treating fibrosis?
That's the million-dollar question. I think at this point we are preventing fibrosis.
Preventing.
We are actually doing the same preclinical studies in mice trying to revert fibrosis. But this is a very difficult exercise because we should not think that we can actually revert complete stricture. You never can revert it. Your mucosa is gone. You could never revert it. But maybe there is this window in between somewhere that we can still target.
Your opinion, to prevent or to treat fibrosis?
If I'm honest, as a scientist, we will try to treat, but if I'm being honest, I think we will be preventing.
Other questions?
Thank you, Debby. It was a really nice talk. And the question I ask you for, you said this fibrosis is really, it's 30% in Crohn's disease, but only 5% in ulcerative colitis. Why is that? Maybe it's probably mainly because of the transmural property of the Crohn's disease? Okay.
Yeah, I think so, yeah.
Okay.
Yeah.
And the second question is, the Crohn's disease is quite common, start from ileum, right? Sometimes ileum and colon as well. So is this fibrosis occurring in colon and also ileum as well?
I had the same question. I also thought it was only apparent in the ileum, but it's not. In Crohn's disease, it can also occur in colon. You can also have
yeah.
strictures in colon, so
Yeah,
it's not only for the ileum. No.
Yeah. So I mean, the fibrosis, if it occurred in the ileum region, all this cobblestone type of fibrosis also occur in ileum.
It is.
It is.
It's
Okay.
affecting both
Both
regions,
anyway,
in fact.
region.
Yeah.
Okay. Yeah. All right. Thank you.
Oh, very nice talk. Really enjoy it.
Thank you.
In relation to, you mentioned these results that the effects of this drug on acute and chronic inflammation. What I don't know if you try that, or what do you think would happen if using this inhibitor during the inflammatory process in mice model, of course, what would be the impacts on fibrosis? Because it's like, in some way preventing, but when the inflammation process is already present in the intestine, what happens if the if the fibrotic process occurs? You know. So in some way, the disease is established already, but not the fibrotic process. So when you have the strong inflammatory in the chronic inflammatory process.
I'm not sure if I understood your question correctly, but it is very difficult to uncouple, of course, your inflammatory trigger. We need the inflammation to build up fibrosis.
Exactly.
But there are some models that only have the inflammatory compartment without having fibrosis. That's true. So that might be nice to compare, indeed, what is actually going on during this acute inflammation, compare both models. But it's very difficult to uncouple. You need inflammation to repair your mucosa, obviously. And it's during that repair that something apparently goes wrong.
Mm-hmm.
In some people and in some models, not in all.
Okay.
But yeah, it's a very difficult matter, what you're trying to tackle. Yeah.
Okay. Other questions?
So for these RAW inhibitors, and it also can be effective in other fibrosis, not just the Crohn's disease. Mm-hmm. Have anybody tried on that?
We have, not we, but Fasudil, it has been used quite often. It can prevent lung fibrosis, can also prevent fibrosis to the cornea. Problem is that Fasudil is not really selective, so it blocks other kinases as well, plus it is toxic. It has some huge side effects on the heart.
Other questions? If not, thank you very much. One last question from my point of view as a clinician. Do you think that in the future we have to stratify the patients with Crohn's disease by the risk of developing fibrosis and to have a reliable marker for this, or is not a very important target in the future?
Mm-hmm. I do think it's important for the physician because, well, I was told that sometimes it's very difficult to make a decision if you see an inflammatory bowel that has stricturing. Sometimes, physicians don't know how to treat. Should they treat inflammation or should they go for surgery? First of all, you treat inflammation, of course, but you might make fibrosis even worse. Awesome. So there you have an issue, I guess. And not everybody is acting in the same way. There is no guideline, I guess.
So we need a reliable marker for this, and probably a specific class of therapeutic drugs, including in the treatment of Crohn's disease only for fibrosis.
Yeah, that is the ideal way to
Thank
do
you.
it. Yeah.